Welcome to More Than Miles, where we use storytelling and expert interviews to empower endurance athletes and healthcare providers. I'm Dr. Kate Mihivik-Edwards, physical therapist, author, educator, entrepreneur, and former endurance athlete.
And I'm Dr. Kacy Saunders, physical therapist, runner, and triathlete, and together we're your co-hosts. Our goal is to always keep our athletes healthy on and off the road, because we know that our athletes are so much more than their body and their sport. We're glad you're on this journey with us. Now let's get to the show.
Hey everybody, welcome back. Today's show, we're going to talk about knee pain in endurance athletes. The reason we've decided to start with this particular injury is because 70% of all runners have knee pain or have an injury in their knee. And somewhere between 50 to 70% of triathletes and cyclists have knee pain. Sometimes it's because of training, sometimes it's because of the way that their body is moving. But we're really going to delve into all of these pieces today. So talk about the risk factors, talk about running form, bike fit, swimming, clinical presentation, and what we can do about it. So let's go ahead, Kacy.
Yeah. When I see a patient with knee pain, I'm often explaining to them how the knee is the victim and not necessarily the culprit, or why the person experiencing pain in the knee in that location. And the reason for this is because the hip and foot have a lot more range of motion available to them than the knee. So if we think about the knee as a hinge joint, so it has, it goes forward and back, there's a little bit of rotation in there, but primarily it's a hinge joint versus the more ball and socket circumduction. We have a lot more degrees of freedom in the hip and in the foot. And so if there's something going on above or below, the knee is in the middle and can get sort of stuck. I don't know how you usually explain this to patients.
Yeah, that's basically what I say. Is I say that the knee is in trouble because it gets stuck between two places. It has nowhere to go. So unfortunately, it is the victim of what's happening above and below it. That means that if you have a lack of range of motion in the ankle, you've had several ankle sprains over your lifetime, and your glutes have shut down, or you can't dorsiflex, that means, flex your foot appropriately, that can cause pain at the knee. If you have a history of back pain and hip instability, that can cause pain in the knee. I like to mention that even if you're diagnosed with knee pain, it may not actually be from the knee. Just in the idea of interregional dependence, we have to see that the back can refer to the knee. We can see that the hip can refer to the knee. Sometimes things like L4, L5 will actually look like knee pain, and you'll come in for knee pain, but it was never actually at your knee. Seeing a clinician that can do a good differential diagnosis and say, hey, this is actually knee pain coming from the knee joint because of things happening above or below, or no, this is just referred pain to the knee, is really important.
Yeah, so getting the correct diagnosis and addressing the problem instead of assuming that's from the knee is what's going to get you better faster, right? And so I talk about this sometimes where, if you think about an injury as a faucet that's on, if you don't turn off the faucet, things are still going to get wet. We need to make sure that we're going through our clinical exam and really hashing this out. Where is this coming from exactly?
Yeah, one of the things you may or may not remember from class or every day around here, a long time ago, differential diagnosis. I always say, pick 3 theories. If somebody comes in with pain, and we'll say the knee because that's what we're talking about today, but say someone comes in and they have anterior knee pain, that means in the front of the knee. What are your 3 top hypotheses about what that knee pain is, where it's coming from? And then, of course, everybody freezes in class and they don't want to say anything, but I usually say make a list of 10 to 20 things it could be, and then rule in, rule out what it is, where it's coming from based on the subjective exam or what the patient is saying to you. So that's really important, that piece, being able to figure it out, getting down to the root cause of where that pain is actually coming from.
Yeah, Kate, I did not forget that at all. And even the other day we were talking about a patient and I said, I picked 3 things that it could be. I don't know why I did that. And you're like, because I made you do that in class. And then the other aspect of this is that when we did pick our hypotheses, you made us explain why it was that certain hypotheses. Or that's why we thought that it could be that diagnosis, in other words.
So you sound a little traumatized.
I'm not traumatized. This is why I'm here, and this is why I am thankful for the education I had. I'm not going to say trauma wasn't involved.
I'm so sorry. Well, I do think that it is important to really be able to break it down that way, because oftentimes things get missed. And a lot of our patients come in after seeing 5 or 6 or 2 other people, and it's because nobody actually listened to their story, and the person said, I have pain in the front of my knee, and nobody looked at their back, nobody looked at their hip or whatever it was, so it was missed. And that's why that differential diagnosis and really being able to break things down and see, okay, these 10 things refer to that area, let's rule them out. Okay, now we really know what we're dealing with is so important. And that's what I think we do really well here. And I think you're very good at it.
All thanks to you, Kate.
I don't know about that. Okay, so let's get down to risk factors, like common risk factors of knee pain. What really drives the knee to hurt, or drives us to hurt our knee?
Yeah, so we talked a little bit about the ankle and the hip, right? So what happens at the ankle and the hip? So I think a lot of runners are familiar with this pronation word, and I love to improve people's relationship with the word pronation because it's often seen as like, oh, I pronate, I'm a bad runner. And that's not true at all. Pronation is a normal part of running and walking gait. So I want to be very clear that pronation has to happen, and it's actually a bad thing if you don't pronate enough, so on and so forth. So what happens with pronation, if you're thinking about collapsing of the arch, right? So flattening out of the foot, that impacts the tibia, the femur, so all the bones that stack on top of it. And so that's going to affect your alignment of your knee in running gait and how the control of that knee alignment while running.
As you said, pronation and supination have to happen. So we hit the ground, we supinate, we move through our stance, we start to pronate. And supination is when we push off as well, because supination is that rigid lever. Pronation is our ability to accept force throughout our entire chain. And I think that's important. The other thing is how we pronate and supinate matters too. So if we pronate too quickly, too late, too early, or we never come out of pronation and move through supination, that can all impact what happens at the knee. So again, pronation is not a bad word. We have to do it to accept the force. But if we're not doing it effectively, then we need to really look at that and look at the foot and ankle and see what's happening from a mobility and stability standpoint.
Right. And so this is really nuanced, and really you have to watch someone run to be able to pick up on these things. I love sending people to running stores, and they do a great job. But, a lot of times they're just watching you walk, which will give us some sort of an idea, but that could look completely different when they run.
Yes, you have to watch a person run if they're coming in with a running injury. We may say this over and over every single podcast till the end of time, but if you don't watch a runner run, you're missing the boat. And understanding a person's running biomechanics and how that works and how everything works together is really important to treat this population, because what they do in walking is not the same as running. In fact, in running, we have a float phase, right, where both feet are off the ground. Walking, we don't. There's just very different things between the two.
At the end of the day, it's jumping from one foot to the other. So what is your ability to control that jump through that entire lower extremity? We can talk about the hip too. So there's a lot of things that can happen at the hip. And of course, we're bringing in lumbar spine as well with this. But one of the big things, our running folks will have heard before is about hip drop, that dropping of the pelvis when you're standing on one foot. This is an indication of hip weakness, particularly the hip abductors. So you think about your Jane Fonda muscle, I like to call it. The reason why this is a problem is because that has, again, an effect all the way down the chain. So for our more well-versed folks, so hip adduction, internal rotation, and that's going to put a little more of a twisting motion through the knee. And this is when we're going to see increased risk for knee injury.
That's right, because it goes into valgus, or the diving in of the knee. And so when you're talking about hip strength and hip, we need to make sure that, yes, gluteus medius, of course, everybody knows that. It's all about the glutes, but it's really not all about the glutes. But glutes are very important in terms of making sure that the hip abductors are strong, but you also need hip external rotators strong, because we talked about how there is a rotational component in the lower extremity or the leg. And if you can't control that rotation, there could be a problem there. And then, of course, moving up, as you mentioned, into the pelvis and lumbar spine, that could be driving what's happening at the hip. It could be driving inhibition in the muscles. It could be driving positions in the hip itself, hip joint itself. And then if we even venture higher, which I love to venture higher, in that thoracic spine can also impact the knee, because if you think about your arm swing, It's a reciprocal movement. As your left arm goes forward, your right leg goes forward, right? I got my left, right, correct?
That's correct.
That's good because I have an issue with that. Right now, I'm basically making an L out of my left hand to make sure I did that right.
Yes, I can attest. I can attest that this happened.
But anyway, as you're running, if there's anything crazy going on in your thoracic spine or your arm swing, that could also impact how your foot lands. You could end up in some relative internal rotation, adduction, and knee valgus, basically knee diving in and everything collapsing if you're not, if you don't have the right mobility or your arm swing is impacted.
Sort of in tandem, if we look at the rib cage, right, which attaches on.
Love you so much for bringing up the rib cage. Thank you.
I thought I would make you. I was like waiting for it. I was like, maybe she's going to give me the chance to talk about the rib cage.
And you did. I love it. You're so good.
Yes, I know. So yeah, if we have a stiff thoracic spine, that's going to affect how our ribs move, which in fact is going to impact our breathing pattern. Kate is so proud of me right now. I think
we're beaming.
I know she is. It's like regurgitating what I learned in class, but no, it's much more nuanced since I've been practicing. But yeah, so if that diaphragm is in a poor position, that's going to affect our core stability, ability to use our abdominal pressure correctly. And this is something we can get into a little bit more, maybe more detail later. The overarching theme here is that if you think about the pelvis and the rib cage, it's a lot of our body. So if something's going on there, it's going to have an impact lower down the chain.
That's exactly right. And so I guess what we're getting into is the entire body impacts the knee.
Basically.
So if you have knee pain and someone has not looked at all of those things, they're probably missing the boat and there could be something else going on.
I like to tell people, you run with both legs, both arms. It's your entire body that's running. It's not just your right knee.
That's right. And you're jumping from leg to leg the entire time. So dynamically controlling how you land is important.
Yeah. Yeah.
So that's running. But we also mentioned in the beginning that knee pain is an issue for triathletes and swimmers. And of course, a lot of knee injuries occur in the running portion of triathlon, but we don't want to forget about the bike and bike fit. I know that that's a topic we really need to address in terms of how our foot is on our bike. So if you think about a bike, our feet are actually locked into position, and that's not what happens with running. And it's the only kind of crazy sport where you're actually locked into position. And if you aren't a cyclist or a triathlete and you've never been locked in, you don't know the terror of the first time that you lock in and then you fall down at the stop sign and turtle.
Yeah, we've all been there. Yes.
It's really important to look at that foot pedal interface. So what I mean is, how is that foot actually locking in with the pedal, and what's happening at the foot will really impact what's happening up the chain in the knee as you're going through each one of your revolutions on the bike. Just a side note there that's important. So having someone who knows how to do a really good bike fit can improve knee pain on the bike. And that might be moving the seat up a millimeter or forward a millimeter, or changing the position of your cleat, moving it back or forward or side, medial, lateral. But all those things are important if you are a cyclist, or even if you're a runner that doesn't call yourself a cyclist and you do some Peloton or you do bike riding or mountain biking or whatever on the side, but you don't quite count it as your exercise, which many of us do. Make sure that you have a good bike fit.
That has to be appropriate, because if you think about bending and straightening the knee, which is a lot of the issue that we get with knee pain, right? And you think about cycling as being a repetitive motion, and like someone training for an Ironman or a half Ironman where a lot of the volume is on the bike. That's where a lot of people gain their aerobic fitness, and it's needed, quite frankly, for the nature of the race. That's definitely going to impact what's going on at the knee when that person goes to run. And the other thing about the cleat and pedal interface, not only does it have to be aligned, but there's a certain amount of movement available there. Float, yep. Available depending on what type of cleat you have, what type of shoe you have. If you have more float, that's going to take more control from the proximal aspect of your body, so your hips, which could have the potential to fatigue out during a longer distance event or a longer training day. Conversely, if it doesn't move enough, then you're stuck in one position, and if that position is not ideal, that could lead to injury as well.
Absolutely. You need to make sure that you fit on your bike correctly, whether you're a triathlete or somebody who's on a Peloton, if you're having some kind of knee pain. And it can be miraculous. I mean, honestly, that's one thing that's different about running and cycling is that sometimes you just have to make this 1 millimeter adjustment on a bike and your knee pain can go away. It's actually really incredible. Everyone thinks it's a miracle. And I'm like, no, that bike fitter was awesome.
Yeah, very small changes, right?
Absolutely. And then if we're talking about knee pain too, just because we're speaking about endurance sports in general and we think about swimming, it's not as often that we always think about like shoulder injuries when it comes to swimming, but the knee can be injured during swimming, especially breaststroke. And I don't know about you guys, but when I first started triathlon, I used to do the breaststroke. I was totally that girl. I was on a mountain bike and breaststroke for my first triathlon.
But you did it.
But I did it. Breaststroke can be something that can really tweak the knee as well, just because of the position that you're putting it in. And just like running, you need to look at the pelvis and the thoracic spine and the lumbar spine in order to see how much movement you're getting there and what's happening at the knee.
Yeah, I don't breaststroke because my hip and spine mobility cannot handle that motion. I joke that I go backwards. I do go forwards while I breaststroke, but it's not very much. So I joke that when I breaststroke, I go backwards.
I really would love to see that, actually. We could video it, right, and put it up on the website, and we can see, here's Kacy's breaststroke. Oh, wait, I think she's going backwards.
She's going backwards. Wait, what's going on here? Yeah, let's make that happen. Not now, it's cold outside, but
yeah, that's true. We could do that. It would be really fun.
It'd be a treat for everyone, for sure.
Let's bring it back a little bit and talk about more external factors. So we talked about the bike fit a little bit, but we should also talk about things that can cause knee pain. So hills, running or cycling on hills can actually increase your chance for knee pain. And why is that?
Going up and downhill, the rhythm of your running and your running form is going to change. So I think about this primarily with running downhill. So if anyone who's run the Boston Marathon, you know that the large portion of the race, especially in the beginning, is downhill, and it feels great. It feels easy until you have to go uphill and you notice your quads are shot.
Trash.
Just gone. And that's because it requires a lot of control and what we call eccentric contractions of the quadricep muscles when you're running downhill. So it requires a lot of control, and it's a very stressful type of contraction for that muscle. And so if you think about that over time, even with training, if you're not running the Boston Marathon, this can really put a lot of stress on the tissues of your knee and really your legs in general. But so I think about that a lot with downhill running, but uphill can have a similar effect too, especially if you don't have great ankle mobility. So if you're trying to run uphill, you're going to need more ankle dorsiflexion. And if you don't have it, you're going to start to borrow it from somewhere else.
And that's usually borrowing it by bending forward at the hip and leaning forward. So it's almost like you're sitting while you're running. And that changes everything in terms of your ability to get your glutes on your posterior chain. And posterior chain is the back of your body. Just think of it that way if you're not sure. But getting your posterior chain firing will be really difficult if you're bending over. You might increase the sensitivity of your nervous system by doing that. So neural tension will increase. And then it just changes, obviously, how your foot hits the ground. It changes your ability to breathe and have your deep core turn on as well. So yes, both running uphill and downhill can certainly impact the knee, as it can impact many other parts of the body. And then there's also shoes and orthotics. You can go any way with this. First thing I'll say, we're not going to get on a soapbox, but the first thing... Not yet. I mean, I can't promise that. Actually, we might in a few minutes here. We're going to try really hard. But in terms of shoes, it's really important that your shoe feels good and fits well. And everybody brings... I love it when my patients come in with like 2 bags of shoes.
Oh, yeah.
And I've had people that want me to watch them run in every single pair of the shoes to see which one they should wear. It's hard because, you know, I could watch someone run all day and I don't mind watching because I like to see the nuances between the different shoes. But the truth is, the shoe that you wear, the most important thing is that it's comfortable. And that's what the research says. It's all about comfort and what feels good to you. We could also talk about shoes for a whole episode, which I think we probably will with somebody from one of our favorite stores. So that's all I'm going to say about that.
Right, exactly. And yeah, when you put that shoe on, you shouldn't feel anything that feels out of place. It should just feel right for your foot, which I know is a very hippie way of explaining this, but
hippie way. Hippy dippy.
Hippy dippy. Yep. Most people know is my style by now. It's starting to come out as I'm getting older.
Oh, you're so old.
I am really old.
You are not. But let's talk about orthotics too.
Orthotics can be appropriate for certain conditions, certain people. And I've seen it be a quick change that really helps with pain immediately, but I've also seen it where it's been prescribed incorrectly. And so again, this comes back to looking at the person's foot, looking at their running gait. Is this orthotic needed or not? The other thing I've seen is people with what is classified as a stability shoe that has some form of pronation control in it already, and then having orthotics on top of that because they always used orthotics, or because when they went to the running store in high school, the person told them they needed them. They just always put the inserts in there. So then we end up really overcorrecting or really pushing that foot into a pretty extreme position, which can have a pretty big impact on the knee as well.
Remember how we talked about needing that pronation and being able to unlock the foot so that we can absorb force? If you're overcorrected, you may not be able to absorb force. So you may end up with lower extremity injuries like medial tibial stress syndrome, which is more shin splints. That's what people call them, shin splints. For a minute, I was like, I don't know what the normal word is. Shin splint. Okay, so shin splints or stress fractures in the foot or even the lower leg and the tibia. So you just have to be careful about that. But like you said, it's true. Sometimes orthotics are good. I don't use them long-term typically. If I do put a patient in an orthotic, it's usually because they're in pain and I want to keep them running while we're getting them stronger.
Right. So the orthotic essentially is offloading whatever irritated issues there, or irritated tissues. Tissues rhymes with issues, but it's not the same thing. So we're trying to offload the irritated tissues by changing the mechanics at the foot while you can work on strength to be able to maintain those changes without the orthotic. And this is how I think about orthotics as well, as a short-term solution oftentimes. And I don't think this is really common knowledge. I think people get prescribed orthotics and they just assume that they need them all the time.
I think you're right, actually. I've had people that have been in orthotics for 10 or 12 years. And the thing is, some people need it. And the other piece is, if people aren't going to do the work, they're not going to get strong. They may end up in orthotics forever. And that's okay if that's your prerogative. You know what I mean? If you'd rather, you have so many other things going on that you just decide to go out and run. I am all for people just staying on the road and running as long as if the orthotic is working for you, fine. Obviously, I think it's better to get stronger. I don't want that to be misheard, especially by any of my patients. Kate, you said. But I do think that it would be ideal to get out of the orthotic if you can and if it's appropriate.
Right, because it works for some people, but it doesn't work for everybody.
That's right. The other pieces I think about running is training. About obviously training is part of running. But I mean about knee injuries is training and overtraining. So if you increase your intensity too much, your load too much, whatever it is, you can certainly get a knee injury. You can get any injury, but a lot of times it's at the knee.
What comes with this too is a change in terrain, right? So I remember when I first moved to Atlanta and went for my first joyous run out of my new apartment, I was in good shape. I had taken 2 weeks in between college and grad school. I had been working out during that time. It wasn't that I was just sitting on the couch. So I was in good shape. I had to walk up some of the hills here.
Atlanta is so much hillier than you realize. I moved here from Boston. I thought, I guess because of the Boston Marathon and just everything, I was like, oh, Boston's so much hillier than Atlanta. And then I got here and I was floored. And it really did mess me up a little. I don't know if I got a knee injury, but I probably did, knowing me.
I did. I think 3 weeks here, it wasn't a knee injury, but I got some Achilles irritation because I think I wasn't used to the hills.
Yeah. So that is definitely something to think about. And we don't always look at our training, how we train, what our stress is like, and say that that's the culprit for our injury. We always want to blame something else. It's my damn knee.
Always the shoes.
It's the shoes. Everybody blames the shoes. It's not the shoes. I'm just going to say it's most likely not the shoes.
Yes, I'm right on that soapbox. We're together. It's usually not the shoes.
Usually not.
Unless you've worn the same shoes for
2 years.
2 years.
And they've got holes in them. That actually makes me laugh so hard. And you know who you are. You know who you are, that has a hole right where your big toe is sticking up, or maybe part of the bottom of the shoe is off and you just don't want to spend the money on a new pair of shoes, or you can't maybe, but you know who you are. Get a new pair of shoes, please.
Please. For everyone's sake.
For everyone's sake. If you come into my office like that, I'm taking them from you and you will leave with no shoes. I've done it before.
Have you really?
Yes, of course.
Oh,
and then
that's brilliant.
I'll say, give those to me. They're for my class. You can't have them anymore.
And then you show them to us in class. Yeah, that's amazing.
And then I also give them like a little discount card for a local running store. And I say, please go in here. They will help you, I promise.
Well, that's nice of you.
Well, you know. Luckily, no one's gotten mad at me for that. They usually understand that it's out of love.
Yeah, it's just tough love. That's all it is.
Tough love. Oh, we always digress, but it's the best.
It's probably better than our plan, really.
Yeah. What plan? You had one?
We did. We have a paper today. We printed it out and everything.
So if you have knee pain, and it is not coming from somewhere else, it's actually coming from the knee, there are a certain set of clinical presentation. There's a clinical presentation, certain set of things that you will notice about the knee. So let's go through that so that people can say, oh yeah, that's definitely coming from my knee.
Yeah, sure. So the big thing I want to make clear about this too is...
Uh-oh, here it comes.
I told you the soapbox was coming. There are diagnoses, so we're going to talk about iliotibial band syndrome and patellofemoral pain syndrome. And both of them are just big catch-all terms for you have knee pain.
Yep.
They don't really explain where the pain's coming from. They're primarily just a subjective diagnosis based on location of pain. So if we're looking at iliotibial band syndrome, we're looking usually at outer knee pain or lateral knee pain. And then patellofemoral pain syndrome is usually in the front of the knee, but it could really be any sort of nebulous, nondescript pain in the knee. And I see patients a lot and they want me to give them a diagnosis because they Googled it. They said, I think I have ITBS. And I'm very resistant to tell them that they have a diagnosis because it could be so many different things. And I'm like, wait, let me do my exam. Let me make sure this isn't coming from your back or your hip. And then once we get to the knee, maybe it's like referred pain from your quad or it's something else. I don't like labeling my patients. I think there's so much more nuance than that. They deserve more than a label.
I agree. Well, that's our whole thing, right? Is there so much more than your body or sport? So you don't maybe need a label. And that happens to me all the time. People want an answer and I understand that. Tell me what it is. I'll feel better if I know what it is. Well, sometimes it's both. Sometimes it's two things. Sometimes it's three things. Sometimes it's a little bit patellofemoral pain and sometimes it's a little bit IT band syndrome. They're not mutually exclusive. And I think that's important to say. There are a couple differences in terms of what you might feel if it's one or the other in our big clinical diagnosis patterning, right? So with patellofemoral pain, you might get more crepitus, which is just a fancy way of seeing creaking at the knee. Although I will say, if your knee makes noise, it doesn't mean there's an injury there. And I think it's important to say.
I used to joke with people, that's just your knee cheering you on.
Oh, I love that.
Yeah, isn't that great? It just brings it nice and lighthearted and it's okay.
I like that a lot. I've never actually heard you say that. Oh, I was missing out for years.
You were missing out. All my little analogies.
That's right. So other than crepitus, other things are prolonged sitting. So if you sit for a long time and then stand up, that's usually what we call anterior knee pain. A lot of people will say patellofemoral pain, or going up and down the stairs. That hurts. That could be patellofemoral pain, but it could also be IT band pain, which is where the waters get a little bit muddied.
Yes.
A lot of limping will happen with IT band pain. A lot more limping and stiffness that'll go from the hip to the outside of the knee. Sharp pain happens more with IT band related things than it does with patellofemoral pain. So there are a couple differences in terms of what you might have, but again, they could happen together.
The reason for that could be totally different between people too. So I tell people, I'm addressing the reason for this. I'm not really treating you like you have IT band syndrome, so I'm going to do this, or you have patellofemoral pain syndrome, so I'm going to do this other set of treatment. It's about why is this happening?
I'm glad you said that, because someone with patellofemoral pain, it might be because of an instability at the hip. Somebody else, it might have to do with their ankle. Someone else, it might be how they're running, they don't have any hip extension, or their thoracic spine and their arm swing is off. So it could be all of these different things causing that knee pain, however you want to label it. So it's really more important to figure out the why than it is the what.
Right. And with both of these, you can have pain with squatting as well. Or I think with IT band syndrome, we also see that first 15 to 20 degrees of knee flexion or knee bending. So like that pain at initial contact. And running downhill often is something I hear with a more IT band-ish type of presentation.
You know, my first time with IT band syndrome, it was because I was living in Boston. I was training for a marathon. I can't remember which one. I want to say Chicago, but I don't know. It had snowed so badly, and there were all these snow piles on the trail around the Charles River. So I decided I was going to run up and down the piles of snow because I didn't want to miss my 17-mile run because, you know, why in the world would I let a nor'easter stop me from running? So I ended up with, I know you're laughing, it's true though. I ended up with IT band pain, and I could not walk up and down the stairs, and I could not bend the knee, and it was very, very sharp, all of the same clinical presentation, because I was literally climbing up these piles that the snowplows had made on the path and then running down.
Yeah, so moral of the story, don't run up snow piles. All of our friends in the Northeast who are hammered with snow right now, as we're looking out our window and we've got a nice sunny, clear day. I think it's in the 50s right now. It's really nice.
You're really just rubbing it in.
I really am. I know. But I'm from Florida, so I'm still suffering a little bit because it's cold.
I didn't even want to wear a jacket today. I thought this was wonderful. I think we should spend the whole day outside. That's funny.
Differences.
Let's bring this back in. And again, I keep saying, let's pull it in. But the reason is, let's talk about, so now we know what the risk factors are for running injuries, especially knee injuries. We kind of know all the things that might contribute to it. And we know some of the clinical presentations, but what do we do about it? Someone has knee pain, they come into the office. What are we going to do? Or what are they going to do?
Well, first of all, I think it's important to note that someone doesn't need to stop running or stop training because of knee pain. There are things that we can change clinically and some simple fixes we can to modify training or change their running to help work through this, essentially. So it's not, we don't want to have that fear of people not coming in because they think we're going to tell them to stop running.
Exactly.
Especially here, we very rarely tell people to stop running altogether. In addition to that, so what might we do? So if we're looking at someone's running gait, there's certain cues such as cadence and arm swing that can have a really big impact. Cadence in particular, if we bump it up just a little bit, so people have, I think, get stuck on that 180 number, but it doesn't have, you don't have to have the perfect cadence, but increasing it a little over your self-selected cadence can encourage you to take smaller steps, and it can correct certain aspects of your running gait that's causing stress on your knee.
That's right. So you don't want to increase your cadence more than 5 to 10%. And by the way, every time you say cadence, I keep thinking about my little puppy.
I know. I saw your eyes kind of light up when I said the word cadence.
Going back to that, you increase it by 5 to 10%. And actually, most people that come into the clinic, their cadence, if they're not an elite athlete, is typically around 165 to 175. And that's fine. You don't have to shoot for this 180 number. And even elite athletes don't always hit 180. Sometimes they're 190. Sometimes they're 175. So don't get stuck on the number. But what you do want to know is that by increasing your cadence a little bit, you can take some of the pressure off the knee. It might help the glutes turn on. There's some research out there that says that the glutes turn on so that they're working more appropriately, and it is decreasing your stride so you're able to land with your foot more underneath your center of mass. So I think that those are two of the reasons, or a couple of the reasons, why cadence manipulation works and is really good, and it's easy. You can manipulate it by using a metronome, which everyone hates. You can change it by working through your watch. You can also do a playlist based on a certain cadence there. So there are a lot of different ways you can change it.
Yeah, Spotify has certain playlists that are to certain beats, and it has like several different ranges. So depending on what you're sort of aiming for, you could use that. I will do a lot of gait training with metronome here in the clinic so that the person can feel that, get the sense of what that feels like. I've had a lot of success with that. But of course, people don't like running with something beeping at them constantly, which I completely understand.
Yeah, I actually hated it when I would do it, but I did it because, you know, if you're teaching someone to do it, you should know how it sounds and feels.
Yeah, that's a fair point. But my cadence is like 190, 195. These little legs need to really turn over to go anywhere.
Here comes the shorty comments again.
I know. At least one per episode.
You know, when you were saying we don't make people stop running because of knee pain, I automatically had this thought. And of course, it's a little bit of my soapbox that I have to just get out. But I want people to know that the more you run doesn't necessarily mean you're going to end up with osteoarthritis of the knee. This is something that a lot of people will say, oh, you're hurting your knees because you're running more. Well, that's not necessarily the case. There's actually research out there that says that runners actually can have healthier knees than non-runners. I just had to insert that because it was in my head, and it's one of my pet peeves is when people say stop running because you're hurting your knees.
Aunt Margie always wants to tell you you're hurting your knees by running.
Oh my God, my grandma, I love her. She used to always say that, oh, your knees are going to be ruined because of running. I love my grandma so much. Other than cadence and gait manipulation, other things that can happen to improve knee pain are obviously manual therapy, which we do. So that's soft tissue, trigger point dry needling, cupping, all sorts of different things in terms of manual therapy. Working on your spine, working on your hip, joint mobility, things like that.
Yeah, so that comes back to what we were talking about at the beginning. What are the risk factors? Why is this happening? So the aspects of PT care that we can sort of manipulate and work through to improve those mechanics, improve the way your body absorbs force during running can help with not only keeping you running, but also resolving the issue ultimately. Sometimes we'll use taping, certain braces. I know you go to like races and people are just coated head to toe in kinesio tape.
I just want them to come in so they can stop wearing the tape and we can help them.
I know, and I don't have anything against kinesio tape. I actually use it, not a lot, but I use it quite a bit for certain things, and it really depends on what's going on with the patient, things like that. And I feel like the knee is one of those places where once someone starts using kinesio tape on it, they'll like never stop. Like you have to have the kinesio tape on.
I don't know. It depends. I think that people do get addicted to it because it feels good and can help. But I also think it's like orthotics in the same realm as orthotics. It's a crutch, or not a crutch. It's a tool. I think that's probably a better word. It's a tool to help you achieve something, a tool to help you achieve pain-free running for a while until you get strong enough. When it really comes back to strength, how do you move your body? The stronger you are, the more you load it, the better you're going to be. And I know this will be another podcast down the road. Strength training for runners. Do it. Load your joints.
Just do it. Yeah, so while we're on the topic of taping, I'll go through kind of how I explain this to people, because people are like, does it work? What is it doing? And so if we look at kinesio tape, it's a really stretchy tape, right? So we can put a certain amount of stretch on it and it can be somewhat supportive, and it feels supportive because of that pull on the skin. But we can't really, it's not like a brace where we're really, really affecting the mechanics of that joint. And this goes for no matter where the KT tape is applied. So the way I explain this to people is it gives you this extra input and how you can feel the tape on your skin, so it can change your movement patterns just enough to make you feel a little bit safer doing certain movements, certain activities. I want to be clear that we're not holding things in place with kinesio tape. It's not thick enough to do that. We do have some tapes that can do that. But kinesio tape in particular is mainly what we call a proprioceptive difference. So it changes your brain's perception of that part of your body, and it makes you feel safer. So if you think of, you're used to feeling this pain with every step, whether it be in your foot or in your knee, and you have this extra feeling of support on that area, it can tell your brain like, oh, it's okay.
Yeah. And that goes with pain science, right? Taking away the fear, taking away that constant input of pain in your brain. And if you can manipulate that cycle, then it can help you get back to a better place.
Yeah. The other thing I think we really wanted to bring up is just because you have knee pain, don't lose hope that it can get better. So this goes along with the osteoarthritis conversation. I think people think of the knee as something that slowly degenerates over time, which is not true.
Well, except for everything in your body becomes degenerative, and it starts to degenerate after age 30. Sorry, but it's cool. It's normal.
I got one more year left.
Oh, I forgot you weren't even in your 30s yet. You just really hurt my heart. It really hurts. You should see her face. She's not only cackling, but she's got this huge smile. That hurts. Okay, we'll move on.
I'm really trying not to just laugh into this microphone right now.
You're a baby.
I'm a smart and accomplished baby. Thank you.
You are. You're very smart and accomplished woman.
Woman.
Sorry. Sorry.
That was so great.
Oh God, we must be near the end of this episode because now we're really going downhill. It's got to be end. We got to end.
We've been floating on our soapbox out in the ocean. Someone needs to pull us in.
Here's a rope.
Here's a rope.
Are you good at tying a lasso?
Am I good at tying? Yes, I am. I'm very good at tying lassos.
You know, Kay actually knows how to do. Kay is our office manager. She actually knows how to lasso people.
Oh my God, she needs to do that. I'm going to ask her to do that on Monday.
Yeah, please do.
I want her to lasso me.
Yeah, it's really cool. We're going to have to, and we don't live in Texas, which is why it's amazing.
That is amazing. She has so many skills that I'm in awe.
Yeah, me too.
Yeah.
All right, on that comment, we're done.
Yeah, we're done.
We're done. Because you don't need to know all of the weird details. I mean, we were actually talking right before this podcast for about 15 minutes and we were laughing so hard. And I thought, I'm so grateful that this isn't being recorded because who knows?
Who knows where that would have ended up.
That's right. Okay, so to reel it all back in again, which I keep doing, it's probably the 5th time of this episode, so we've got to watch ourselves. The biggest things to know about knee pain are, one, it's not forever most of the time. I mean, obviously there are cases where it is, but don't lose hope if you really haven't looked into all the things that we've talked about. If you're a runner and you have knee pain, or a triathlete and you have knee pain, we need to watch you run. We need to watch you on your bike. We need to watch you in the pool. Okay. And we have to see what those movement patterns look like. You need strength. Running does not make you strong. It makes you strong, but not in all the right parts, right? So just because you run doesn't mean you're strong. It doesn't mean that your legs are strong enough. I just have to say that. You have to do strength training. And then also, there are different types of knee pain, and there are different reasons why the pain will occur at the knee. It doesn't necessarily have to be from the knee joint.
That was a beautiful lasso, Kate.
Hey, thank you. All right. Well, thank you so much for joining us.
Yeah, we'll see you next time.
Thank you so much for hanging out with us. We hope that you enjoyed today's conversation. As you can tell, we absolutely love spreading knowledge about endurance athlete health.
Be sure to subscribe and rate the show on Apple Podcasts, Spotify, or whatever platform you happen to be listening in from. It really helps us get the word out about our show so that we can reach more awesome people like you. Be sure to share the show with your friends, running buddies, training partner, family, dog, scream it from the rooftops, whatever works for you. See you soon.